Okay, thank you very much once more for joining. And today we're going to learn from Professor Frank, and he's going to share his experience on the management of tetralogy of Fallot.
Well, thank you very much. I think you can start. You have the video, so just start the video and then we'll take the questions afterwards. We are behind time, so please.
A very good evening to you all, and welcome to this month's webinar hosted by the Association of Future Cardiothoracic Surgeons. Today's discussion is on understanding the congenital heart defect referred to as the Tetralogy of Fallot. Hopefully, you will gain some insights that will be helpful to you as you embark on the journey to become a cardiothoracic surgeon yourself. My name is Prof. Edwin. I'm a cardiothoracic surgeon working principally in the field of pediatric and congenital heart surgery. I'm also the Dean of the School of Medicine at Ghana's University of Health and Allied Sciences in the Volta region. Let's start with some basic definitions. Before we do that, I want to show you, give you this case scenario, which is a 23-year-old woman in Accra who delivered an apparently well female unit. The mother and baby were discharged home within 24 hours of delivery, but about 3 months of age, the baby started experiencing paroxysms of irritability and breathlessness, requiring several visits to the local clinic almost every 2 weeks. The doctors thought that this was a case of early bronchial asthma and would usually give bronchodilator nebulizations. But when the child turned 9 months old, she experienced another episode of the so-called asthma, but with the difference that this time the child was unconscious. Of course, the doctors panicked and quickly referred the child to the nearby to the teaching hospital in Accra, where detailed investigations revealed that the child had actually suffered a cerebrovascular accident. The child was cynosed, and therefore a congenital heart defect was suspected. Echocardiogram later revealed that the child actually had tetralogy of Fallot. So what exactly is the tetralogy of Fallot? How does it cause a stroke in such a young child? And what can be done about it in our environment? These were the questions that the mother was posing to the doctors. So let's assume that you are the doctor. What would be your answers? That is what this webinar is about. What kind of answers are you going to give the mother to ask you such questions with her baby? And that is the CT scan. You see the HCL and coronal views of the CT scan. The dark areas that you see there, that's actually gray matter that's been lost. So you can see how large the infarct was. That's the sagittal view. Again, you can see how extensive this lesion was. So first of all, let's get some definitions right. It's important that we understand exactly what congenital heart defects are. First of all, we need to understand that these are structural abnormalities. They are abnormalities in the structure of the heart and proximal blood vessels that are present at birth and have actual or potential functional significance. The functional significance means that they affect the function of the cardiovascular system one way or the other, and therefore have the potential for causing disease either presently or later in the future. So those are the four characteristics of what we call congenital heart defect. It's a structural abnormality. It involves the heart and proximal blood vessels. It is present at birth, and it has actual or potential functional significance. How are these classified? The congenital heart defects are classified on the basis of the presence or absence of central cyanosis. We are not talking about peripheral cyanosis. We are talking about central cyanosis, the one that you can see bluish discoloration of the tongue and mucous membranes of the mouth. And so we generally have two broad groups, cyanotic and acyanotic. So cyanotic congenital heart defects are those that are attended by central cyanosis. Acyanotic congenital heart defects are those that do. And I have to mention here that the tetralogy of Fallot is the commonest congenital cyanotic congenital heart defect that you will encounter in clinical practice. So it is an extremely important lesion to understand and understand very clearly. How common are these defects? When we say congenital heart defects, sometimes people think there are some rare, insignificant issues, but these are very, very common. The worldwide incidence of congenital heart defects, which do not vary that much across geographical locations, across cultures, is about 8 per 1,000 live births. That means that for every 1,000 children who are born live, you can expect 8 of them to be affected by congenital heart defects. And we did a study and published it in the World Journal. This was in 2017. Heart defects, birth incidence. If you put these 7 countries together, their birth incidence is more than 50% what you find on the whole continent. So it tells you how. I'll find what congenital heart defects are. What about tetralogy? When we say tetralogy of Fallot, what do we mean? So tetralogy, of course, means 4. It means that there are 4 pathologic defects. Fallot is the lesion was named after the French physician Louis Etienne Arthur Fallot, who in 1888 entity. So it is named Tetralogy of Fallot. What are the components? The first is right ventricular outflow tract obstruction. A lot of you would have heard that being referred to as pulmonary stenosis. It is right in a certain sense because oftentimes the pulmonary valve is the nose, but it is more than just pulmonary stenosis. It is right ventricular outflow tract obstruction. Right ventricular outflow tract is the part of the right ventricle immediately below the pulmonary valve. It also includes the pulmonary valve and its annulus, and the area of the main pulmonary artery just above the pulmonary valve. So that is what we refer to when we say right ventricular outflow tract. And that area of the right ventricle is narrowed, it is small in patients with tetralogy of Fallot. Now, that right ventricular outflow tract obstruction, as you can imagine, would cause or would precipitate right ventricular hypertrophy as the ventricle tries to pump.
Hello, everyone. I'm sorry, I think we are really having very serious network issues from the host end. Please just bear with us. Thank you so much.
Typically, you find this below the aorta, and the aorta in this about half of it is on the right ventricle, half of it is on the left ventricle. That fraction can change or can vary. But when we say overriding aorta, we are talking about the aortic root overriding the crest of the ventricular septum where the VSD is. I'll show you images of that so you can understand. All right, so this is a graphic that depicts the lesion we are talking about. So there you are going to see this is the right ventricular outflow tract. So that's the right atrium, that's the right ventricle. The right ventricle would normally empty into that. That's the pulmonary valve and the annulus. You can see the pulmonary valve annulus there. That region just below the pulmonary valve, as you can see, is narrowed by some muscular band. it equalizes the pressures between the left ventricle and the right ventricle. So it is not as though blood is passing from the left to the right or right to the left ventricle. Blood actually is pumped by both ventricles directly into the aorta, as you can see. So the than the left ventricle. That is the ventricular septal defect, and you can see it will allow blood to go across from one ventricle to the other. But in this case, because the ventricular septal defect is so large, it equalizes the pressures between the left ventricle and the right ventricle. So it is not as though blood is passing from the left to the right or right to the left ventricle. Blood actually is pumped by both ventricles directly into the aorta, as you can see. So the right ventricular outflow, part of it goes into the aorta, the other part goes into the right ventricular outflow tract. But because of the obstruction, a smaller amount goes into the right ventricular outflow tract. So that is what tetralogy of Fallot is. So this is the aortic root, the part that bears the aortic valve. And you can see normally this whole thing is on the left side, it's committed to the left ventricle. But here you can see that's the ventricular septal defect there. That's the top of the ventricular septum, that's the crest of it, and you can see the aorta. When we say overriding, the aorta is actually sitting astride the crest of the ventricular septum. So that's what we mean when we say overriding aorta. All right, so that's the graphic. Now, this is a morphology specimen, of course, taken at post-mortem. The right ventricle has been opened in its long axis. The anterior wall has been flipped open. So what you see here is the tricuspid valve, and you can see the ventricular septum. But you can see the very large ventricular septal defect. Behind the septum is the left ventricle. That's the ventricular septal defect. As you can see, part of the aorta, the right ventricle. This is the part that is connected to the left. The part that's anterior to this would be in the right ventricle. And that is the right ventricular outflow tract. You can see the pulmonary valve there. That's the main pulmonary artery. You can see how small it is compared to the ascending aorta, which is that large. And you can see the narrowing just below the valve, the narrowing of the pulmonary annulus and stenosis at the valve, and the narrowing also at the main pulmonary artery. So what we mean when we say right ventricular outflow tract obstruction is that obstructions extends from the subvalvular area across the valve into the supravalvular area. So that is the right ventricular outflow tract obstruction. Again, here you can see how thick the right ventricular wall is because of the right ventricular hypertrophy. What happens to patients with tetralogy of Fallot who do not undergo repair, who do not have treatment? As you can see from is the right ventricular outflow tract obstruction. the fact that the ejection of blood from the right is obstructed. That is the first and most important thing. In fact, the severity of the right ventricular outflow tract obstruction determines to a large extent the clinical features that you see. Now, that obstruction is both static and dynamic. The static component is the fact that the pulmonary valve, which is a fibrous structure, is stenosed. That stenosis is static. It is stenosed. It is narrow. It is thickened. But then there's the dynamic component of it. The dynamic component is the part which is below the valve, the subvalvular region. So as I showed you before, you see the muscle bands, abnormal muscle bands that are there. Those muscle bands are believed to undergo spasm. And when they undergo spasm, they will even worsen the already poor right ventricular outflow patency. And so you have this static and dynamic components of the right ventricular outflow.
Oh my goodness.
Part of it goes into the aorta and part of it goes into the right ventricular outflow tract. Of course, the fraction of which goes where is dependent on the severity of the right ventricular outflow tract. So what are the consequences of these two important pathological agents? The first is that the right ventricular outflow tract restricts pulmonary blood flow, and therefore there's a reduction in the pulmonary blood flow. Clinically, you see that as cyanosis. In other words, if you put a pulse oximeter on this patient's finger, you are going to see that the SpO2 is below 90. Typically, that's what you find. It also creates what we call a right to left shunt. A right to left shunt, what you are talking about is there's a communication that allows blood from the right side to gain direct access to the left. In this case, we are talking about the right ventricle pumping blood directly into the aortic root. So that's what we mean when we say. Imagine already the amount of oxygenated blood returning to the left atrium from the lungs is reduced because of the right ventricular outflow tract obstruction. Now it is even more compounded because the oxygenated blood from the right ventricle is being pumped into the aorta. So there's a combination of reduction in pulmonary blood flow and the right to left shunt that causes the cyanosis that we see in these children. But it also means that, normally if somebody forms a clot, a child, an adult, whoever forms a clot in their lungs, in their legs, in the systemic circulation, that clot tends to be ejected into the lungs where there are mechanisms to deal with that clot. So it doesn't usually sometimes happen, are dealt with by the lungs without any clinical sequelae. However, in the case of tetralogy of Fallot, because there's a right to left shunt, it allows what we call a paradoxical embolism. In other words, the clot that would have otherwise gone to the lungs bypasses the lungs and goes directly to the systemic.
Hello, can any of the hosts hear me?
Hyperviscosity sometimes causes cerebral venous sinus thrombosis because the hyperviscous blood does not flow too well to the cerebral venous sinus. So in this child that we're talking about who had a stroke, two things could be responsible, either a paradoxical embolus that has gone up into the brain or cerebral venous sinus thrombosis that could have resulted in this. All right, so having understood the pathophysiology, what are the clinical features and what do we find when we investigate these children? First of all, it's important to understand that the timing of presentation is important. Typically, most children with what we call classical tetralogy, which is tetralogy that is not complicated by any more defect than what you've already described, will not really be symptomatic until about 3 to 6 months of age. So we will call that the usual presentation. So if a child with tetralogy is born, normally they are deemed to be normal, they are sent home if in our environment. Elsewhere, they check pulse oximetry and may be able to pick these things. But usually, the symptoms will start to manifest as found in this child between 3 to 6 months of age. If the child presents earlier than 3 months of age, we we tend to consider that as an early presentation. Often it is because the lesion is probably more severe or there's an additional lesion that is forcing this early presentation, something like pulmonary atresia. It may force earlier presentation than the usual 3 to 6 months. They are in our environment because we don't usually screen for these things, and because, like in this child who was sent to the clinic, doctors think it's asthma, and it may go on and on and on and on and on. You may find that the child may not present to the appropriate medical authorities until beyond 6 to 12 months of age. Under those circumstances, we say it's a late presentation. So that is the timing. Timing is extremely important for determining how you are going to manage these things. All right, so the hallmark of the clinical presentation is actually cyanosis, central cyanosis. So if you see any child with central cyanosis, you have to assume that child has got congenital, cyanotic congenital heart defect, most likely tetralogy until proven otherwise. That is what we usually see. Any child with central cyanosis has got tetralogy of Fallot until proven otherwise. So you need to look out for that. The other feature is effort dyspnea. These children tend to get tired easily because of the chronic hypoxemia. In older children, you are going to find that they can't keep up with playing with their mates. You find their mates playing soccer and they are sitting somewhere watching. When they are feeding or when they are moving around, they don't move around as quickly as the others. They can't keep pace. That's effort dyspnea. And then they have what we call hypercyanotic spells. Some people call them head spells. Hypercyanotic spells, remember I mentioned that the obstruction is static and dynamic. So you have a child who has his usual cyanosis. Maybe his SpO2 is about 78, 80, and he's walking around his cyanosis is his usual stable self. But then when the right ventricular infundibular muscle undergoes spasm, that cyanosis may drop even further. Sometimes it drops to the point where the child actually becomes unconscious. And it's all because of, we call that a hypercyanotic attack. Young children tend to get that frequently. In older children, you tend not to see these hypercyanotic spells, but they are a very prominent feature of tetralogy of Fallot. In older children, you see them squatting. So you'll find that this child is walking around, but then squats. The reason they squat is when they squat, it tends to improve the pulmonary blood flow. And the children tend to find that when they tend to get better. So they instinctively tend to squat. But the child may also present with complications, as I described to you earlier. So some of them may present with cerebral thrombosis, cerebral abscess. That's another one. You may get a paradoxical embolism. And then you may get what is called hyperviscosity syndrome, where the blood is so thick that cerebral perfusion is compromised. The child presents with headache, they are not able to concentrate, they get blurring of vision. These tend to happen in older children who've had chronic cyanosis for quite some time. So that is called hyperviscosity syndrome. There's another feature or another phenomenon, what we refer to as pink tetralogy. Pink tetralogy are patients with tetralogy where the right ventricular outflow tract obstruction is there, but it's not that severe for them to have obvious cyanosis. So if you put a pulse oximeter, you may find that the saturation is 90, 91. If you look at their tongue, it doesn't look obviously blue. But if you do the echo, there is no doubt that the child has got tetralogy of Fallot. So we call that group pink Fallot. The other thing you are going to see with these children is clubbing. There's clubbing of the toes and fingernails. And there's another prominent feature. When you listen to the precordium, there is usually an ejection systolic murmur in the pulmonary area. Mind you, the murmur does not come from turbulence across the VSD. Remember, I said that the VSD is so large that there is no shunt effectively between right and left ventricle. So the murmur you get in tetralogy does not come from shunting across the VSD. The murmur actually results from turbulent flow across the right ventricular outflow tract. So that is what is responsible for the murmur. You usually hear it in the pulmonary area. Second left intercostal space just by the side of the stem. Imaging is extremely important in making the diagnosis. There are several other blood investigations you can do, but to establish the diagnosis, one needs to do chest X-ray, which will show a reduction in the pulmonary vascular markings, what we call pulmonary ischemia. The cardiac silhouette is typical in shape. It is called a boot-shaped heart. You look at the heart shadow, it looks like a boot, and we call that a boot-shaped heart. If you do an ECG, you are going to see right ventricular hypertrophy, which is one of the characteristics of this lesion. Polycythemia, you will find if you check the peripheral blood film, the HBs are typically greater than 16. You are going to find that the hematocrit is usually higher than 45. We've seen cases where the hematocrit goes as high as 60 to 70. These children are at risk for hyperviscosity syndromes.
Hello everyone, please can you get me?
Yes, we can.
Hello everyone, please can you get me?
Yes, we can.
Yes, I can.
We really apologize for this technical delay we're facing. Network is really not the best. So I'd like to plead with Professor Frank if we can share the video on our YouTube channel so that we can access it directly from there at any time. Because right now it's very challenging to maintain a consistent stream throughout the webinar. So I would like to request if Professor Frank can grant us that permission so that we stop these challenges that we're facing and not waste up and time and not be able to be efficient during this webinar. Professor Frank, please, are you with us?
Yes, I'm with you. I've been trying to contact you, but I'm not getting any response. Yes, I have no problem with you doing that. You can put it on your YouTube channel for interested people to have a look at. It's a shame that it hasn't worked out the way, because usually these webinars, people need to hear exactly what is going on so they can ask their questions. Unfortunately, I have another appointment in about just half an hour, so maybe we should end it here. But if anybody on the call has any questions, maybe in the next 5 minutes I can answer that. Otherwise, I think we should call it off.
Thank you very much, Professor, and thank you very much to everyone who turned out for this webinar. We are really sorry, and we deeply apologize for the technical difficulties and everything is not going as planned. So we're going to share the video on our YouTube channel and share with us all so that we can access it directly from there. We are really sorry, and we wish you a good night. And we're going to make sure that this doesn't happen again in our subsequent webinar. Thank you very much for keep supporting us and keep being with us. Thank you and have a good evening.
Hello, Frank.
Yes, you can get your questions and I will forward it to Professor Frank, and I think he'll be happy to help. But really, right now, we're having a lot of technical challenges. Daniel, yes, you have the floor.
Okay, thank you very much. I'm right to give Frank Edwin. I wanted to ask about the concept of Tetralogy of Fallot. Thank you.
Yes. Yes, Daniel, can you repeat your question again?
So I wanted to ask about the concept of TQA. I've seen that there is an aspect of Tetralogy of Fallot, a group of them that are referred to as TQA. I wanted to get a bit of clarity on that.
Okay, all right. So thank you for that question. So, unfortunately, I mean, we couldn't hear much of what was going on, but typically the child with Tetralogy of Fallot is blue, he's cyanosed. The reason he's cyanosed is because of the reduction in the pulmonary blood flow and then the right to left shunt. Now, that reduction in the pulmonary blood flow is typically a result of the right ventricular outflow tract obstruction. So the severity of the right ventricular outflow tract obstruction determines the severity of the cyanosis. The more severe the obstruction, the more the reduction in the pulmonary blood flow, and therefore the less the amount of oxygenated blood that is returned to the left atrium and subsequently pumped into the systemic circulation. So you can imagine that patients who have got very severe right ventricular outflow tract obstruction are the ones who are going to have very severe cyanosis, and therefore when you observe them clinically, they will look very dark or blue. Now, there is a subset of patients with tetralogy in whom the right ventricular outflow tract obstruction is mild or moderate. It is not that severe. And so the reduction in the pulmonary blood flow is correspondingly mild. for these kinds of patients, you would not be able to see with your naked eye, the unaided eye, that the oxygen saturation is low. So for example, if you put a pulse oximeter on their finger, the pulse oximeter may read 89, 90, 88, thereabouts. If you ask them to show you their tongue does not look obviously blue, like the typical child with tetralogy of Fallot. And so, because with the unaided eye, they do not look cyanosed, they are more on the pink side. We refer to them as pink tetralogy. Pink tetralogy. The reason we call them pink is that they are not obviously blue. And the reason they are not obviously blue is that the right ventricular outflow tract obstruction is relatively mild. So that is one way to explain these group of patients we call pink tetralogy. There is another scenario where you may have collateral flow, where the compensatory reaction of the body to reduction in the pulmonary blood flow, typically that is by development of collaterals. If the collaterals are sufficient, they may blunt the cyanosis and the patients may become pink. And so typically when we say pink tetralogy, we are referring to this subset of patients. The usual anatomic substrate is a mild to moderate right ventricular outflow tract obstruction. Thank you. I think I see Ahmad Buhari. You can ask your question, please.
Good day, sir. Thank you very much for taking the time out for this event. I have a question that I wanted to ask. I was hoping maybe after the video, I would have been able to get some of those information across, but then it was one of the things I had in mind coming into this program. I'm currently in my senior pediatric posting, and I came across a patient, a 10-year-old male who has tetralogy of Fallot. So he has very central cyanosis and some of the most severe finger clubbing that I've ever seen. Already has the drumstick fingers there. And again, from one of the previous events that I attended with one surgeon from the US, I think he was mentioning about, or spoken about some of the challenges that they have there by the time they are trying to do corrective surgeries for these older, some of these older patients, by the time they pass this period where they could do the corrective surgery. So I was wondering, like, what are the things that can be done for this particular patient? Do the normal corrective surgeries, the shunts, and the other typical things still work in this scenario when you have patients that have these older patients that have survived with it for this long period?
Okay, thank you, Ahmad. So that was the reason why in the video I was talking about the timing of presentation. So the usual, what you call early presenters, usually 3 months or less. The usual presenters are between 3 to 6 months. And then you have anything beyond 1 year, we say they are late presenters. There are challenges with these older tetralogies because these patients have had long-standing chronic cyanosis. And then they've also had long-standing right ventricular outflow tract obstruction. These have got their own repercussions on the physiology of the system of the child. So if you take chronic cyanosis, for example, chronic cyanosis, typically you are going to have issues with coagulopathy. You are going to have platelets that are dysfunctional. You are going to have ischemia, which is generalized. So you are going to have generalized myocardial ischemia. So in your child, this child who is 10 years old, you can imagine if his SpO2s have been 60s to 70s, he's been living with that for all this time. His myocardium has been ischemic for all this time. It has implications. The same goes with the right ventricular outflow tract obstruction. So long as the obstruction is not mild, you are going to have increasing severity of the right ventricular hypertrophy. So the right ventricle becomes fairly non-compliant even after you repair them. The challenges with operative repair or operative intervention for the older tetralogies is based on these features. The fact that you may have a coagulopathy, platelets that may be normal in number but dysfunctional. You are going to have reduction in clotting factors, and so these patients tend to bleed. They've had chronic cyanosis. there's been attempts by the body to form a lot of collateral circulation to get blood into the lungs. And so when you operate on them, they tend to bleed. Post-operatively, you have a lot of bleeding issues. If you are in a center that does not have the support to manage that, that can be problematic. So for example, you may need to have platelet concentrates, you may need to have blood products, fresh frozen plasma, cryoprecipitate, whole blood. If your center does not have adequate support, and you operate on these patients in terms of what you call primary repair, then these are the challenges that you tend to have. Long-standing right ventricular hypertrophy, long-standing right ventricular outflow tract obstruction also tends to make the right ventricle fairly stiff. So it becomes hypertrophied. It is not able to relax like a normal ventricle. The normal ventricle is supposed to contract and relax. It contracts to eject blood. It relaxes to receive blood during the venous return. These hypertrophied non-compliant ventricles are not able to relax sufficiently to receive the venous return, and therefore their output tends to be poor. And so post-operatively, when you have repaired and relieved the right ventricular outflow tract obstruction, you are going to find varying degrees of right ventricular dysfunction. And so these are some of the challenges that you get: post-operative bleeding, post-operative right ventricular dysfunction that may progress to what we call low cardiac output syndrome, when the right ventricle does not perform as well as it should. In fact, there's an entity which is called restrictive physiology, right ventricular restrictive physiology, that tends to occur in the post-operative period after operating on these older children with tetralogy. The way we have tended to go around such issues is, if we have older children with severe chronic cyanosis, we tend to repair them in two stages. We will initially do a shunt, a right to left. We will do a systemic to pulmonary artery shunt. That way, you would increase the blood flow using the shunt. The cyanosis tends to resolve. It doesn't completely go away. You are targeting an oxygen saturation of around 87 to 89 if you do an adequate shunt. And then you would wait. Once the cyanosis has gone down, you are going to find that the hematocrit comes down, the coagulopathy improves, and then we will usually go and repair, do a complete repair 18 months to 2 years after the shunt in these older children. That tends to deal with the coagulopathy issues. But the issue with right ventricular hypertrophy restrictive physiology, that is still there, and it's something you will need to have to deal with in the postoperative period. Yes, so if you go to Europe and America, advanced countries, places where they have facilities to diagnose these children early, they don't present this late. You rarely find children 10 years old who are born in the US or in Europe coming for repair at that age. Most of them are repaired in infancy, and you don't tend to get these problems. But in our part of the world, this is the norm. The average age at which we tend to see patients for repair is about 8 years. When it comes to the shunt, our average age is around 4 years. So this is a problem. There are definite issues with repairing them late. Those who survive to that age, and they tend to have quite a few problems in the postoperative period. But this is the way we tend to go around them. If we figure, we assess the child and figure that the postoperative period is going to be stormy, then about a year or two, and then go back and do the total repair. You close the shunt and then do the total repair, and you tend to get a better postoperative course. So that's the way we manage these children here.
Thank you very much, sir.
Okay, are there any further questions? Okay, so I'll revert to the hosts now. Thank you very much.
Thanks so much, Professor Frank. We are grateful for having us on this meeting, even though what we anticipated did not kind of work out, So we are so sorry. So we are going to send the video to the YouTube channel so people can watch. And I think if there are any questions, I don't know if we can give out your email address for people to like send you a mail privately so you can respond to the mail. Questions via your mail.
Yes, that's fine. You can do that.
Okay. Let's see. I think I'll be dropping the mail on the chat box and on the AFA group right now. So please just hold on. Let me drop the email address. Yeah, so that's the email address. So if you have any questions or like something you need to clarify, you can send Professor Frank a mail. We are so sorry about the situation this evening, sir, and we appreciate your turning out.
No problem. Thank you very much.
Thank you so much, sir. Good night, everyone. Thank you for attending the webinar. Have a beautiful weekend.